Okay, let's get started with today's webinar, Rural Healthcare Transformation Program. And our moderator today is Rocco Gonzalez. He's a board member of our local HIMSS chapter, the Midwest Gateway chapter. He's also Integrated Health and Social Care Informatics Director. So I'll turn it over to Rocco and he can introduce our panelists today.
Perfect. Thank you, Ed. So I'll share my screen so we can make sure it works. Mhm. Let's
Yep,
get,
beautiful.
I think I'm sharing the wrong
Yeah,
one.
that was sharing.
There we go. There we go. All right.
Okay, even better.
Good morning, everybody. So welcome to our Rural Health Transformation Program panel. Really, it's to think through and to rethink healthcare in rural Missouri. So I'm Rocco Gonzalez. I'm our chapter advocacy chair, really working with our legislators in Jefferson City, other key stakeholders throughout the state with how we can really promote health IT, really just health technology, health innovation throughout our state of Missouri and even parts of Southern Illinois. And like Ed said, I'm part of Mercy, full-time gig, integrated health and social care informatics director. So I'll be moderating the discussion and starting with introducing our panelists. So we have Heidi Lucas. She's currently the executive director of the Missouri Rural Health Association. I'm not going to go too deep into everyone's bios because honestly, all of them have done a lot of really important work, all for different parts of our healthcare system. But she's really coming, as her role shows, really at that rural health provider perspective. So what does it look like to actually be a rural health provider here in our state? Then Kemper, who's the CEO of Lewis and Clark Information Exchange. We know that technology is going to be increasingly relevant for how we truly transform rural health. And Kemper has a very unique dynamic and perspective of how technology, interoperability, really how do we shift this dynamic of the urban rural divide. So she'll be able to give a lot of good context on the technology side. Then we have Lisa Nelson, who's a strategic lead over at Freeman Health System down in Southwest Missouri area. She has had a lot of experience doing like health equity type of initiatives. And if you all are aware of different torch models, the transformation of rural community health, that really was a pilot last couple of years for the state of Missouri. She's had a lot of experience working with similar kind of hubs that are going to be really important for the success of connecting the social care, so this community-based organizations, to the clinical. And last but definitely not least, Noah Wolthausen. He's the head of healthcare innovation for BioSTL. So they're a really relevant incubator. I would say a huge part, a huge asset to really the St. Louis region, but also the whole state, because he's giving a lot of good perspective from the private sector, like I would say startups, equity, things that are really trying to come into healthcare to change it for the better and to understand how do we start to look differently at maybe old problems. So I'm really excited to have all of them give their own perspectives on exactly what we can do to rethink rural healthcare. Before we get into the questions, though, gotta tell you all what we're up to here in the Midwest Gateway chapter of HIMSS. We have over 1,000 members. We have a ton of people on LinkedIn. So if you are not a member, consider joining. It's very easy. But also, if you are, definitely join our LinkedIn page along with Facebook. We basically have a lot of good social media coverage. And not to toot our horn too much, really the last few years have been really critical for how we've tried to be as much as we can be that facilitator to health IT innovation, discussion, and just developing good partnerships across our community. So we've gone from bronze to silver, and last year we got gold as a HIM chapter. So we cannot be stopped. And lastly, if you liked what you're seeing today, and even if you maybe didn't like it that much, definitely look at what we have going on in the next month or two. Automation in Action, that's going to be over at the Microsoft Tech Center, actually very close to BioSTL. But looking at Mercy's Operational Edge, sponsored by UiPath and Accelerate. And then we have our summer social. So super great event. We do it every year, along with our winter social over in Creve Coeur for the Bristol Seafood Grill.
And both of those events start at 4:30. Just
Perfect.
FYI.
Thank you, Ed. 4:30 start time. And can't do this without our sponsors. So just taking a second just to understand all the different organizations that have been really important, really critical for our success and ensuring we can do events like this, that we can do events like the Summer Social, and really just connecting the dots between what's relevant, what's practical, and actually helping not only members, but really the greater healthcare ecosystem. So without further ado, we're going to start with the very first question. Also, as you all may or may not know, Zoom has like the Q&A functionality. So there's the chat, but an additional functionality, if you just click on the three dots down there, is the Q&A. So any questions you'll have, definitely feel free to put them in there because I don't want to lose them. Don't want you to forget them. So we have them tracked so that by the end of the session or the end of our like panel structured time, we can get back to those questions. So Q&A section, check it out if you have any questions as you're listening to the panelists. All right. Felt appropriate for the first question to really be framing the rural health challenge. So when we talk about rural health transformation, what does success actually look like in 3 to 5 years? Whether it's for the patients, for the clinicians, providers, and the communities themselves. So really, I mean, the first question, whoever wants to be brave and take it, it's all you.
I'm starting. So, hi, everybody. Like Rocco said, I'm Heidi Lucas, Executive Director of the Missouri Rural Health Association. So, we have been following the Rural Health Transformation Program very much in depth at my organization, and we are grateful for the funding that is coming in through that program. You know, it's money that we've been asking for decades, literal decades. Unfortunately, it is under the kind of umbrella of some cuts as well. So we are very concerned about the Medicaid cuts coming down the line. And our goal and what we think success would look like with the Rural Health Transformation Program is creating that foundation. So creating a foundation of working together, of collaboration in our rural communities between the different healthcare providers, the social service agencies and such, for to lay that in order to help mitigate harm that might come from the Medicaid cuts that we're staring down the barrel of. So our hope is that, you know, that will really lay the foundation for folks to really start working together and put us in a good position for the future.
Thank you, Heidi. Noah, any other thoughts?
Yeah, thanks, Heidi, for that good framing. And I think when we think about us, our roles as conveners and ecosystem builders, it's really to set up our constituents, our rural health providers, organizations for success. Because as everybody knows, the kind of caveat here with this, the money that's coming is that it can easily disappear if all of the outcomes and the things that we're trending towards are not hit in just the first or second year. So I really think it is coming down to implementation science, foundation work, all of those things that are going to make the innovations and technology successful. We, as the conveners and ecosystem builders, need to take a good hard look at, are we actually setting up our partners for success? Because all of that infrastructure could be built. That could be a large investment, and it could also go away very quickly. So I think that an onus on ourselves to really think about, what does sustainability look like? Because that, I think, is the real win there.
Would pick up from Noah on that point about sustainability. And I think that sustainability, if we're successful, will come in terms of the relationships developed between the health and social care entities in the rural communities and the alignment between them. Healthcare is often siloed for many reasons, but I think that Missouri's torch care model in particular fosters this alignment and these conversations very intentionally. And we have a lot as different types of organizations to learn from one another very quickly this year about the challenges in each of our landscapes and how this funding and this timeline can be leveraged to meet several of those challenges and which are most important to prioritize for kind of the common community progress forward.
Awesome. And Kemper.
Yeah, hey everybody. As Rocco said, my name is Kemper, CEO of Lewis and Clark Information Exchange, Lacey for short, because it's a super long name. And to just, come on the caboose of this conversation and this question, I'm going to pull out a little bit. And I think when we look at healthcare and success, it's really your zip code not dictating your health. And how do we make sure we support the crafting of these programs and this funding to ensure no matter where you live in the state of Missouri or whatever state's being impacted, how does that not impact your health in a negative way? And how do you have access? And then on our side, on the data side, is how do we make sure your data is where it needs to go and is being used to inform your care in a positive outcome? So when I look at what success means within the Rural Transformation Program is that where you live is your home, and it is also where you get your care and your positive health outcomes.
Amen to that. Yeah. And I think that some terms that just seem to keep bubbling up. Sustainable is critical because, as we've talked about, this money can come and go quickly. So ensuring that it's not just a quick fix. But unfortunately, relationships take time to build. Moving at the speed of trust is a phrase I use a lot and something that can be very difficult and just take time. Can't really rush it. But in doing that, ensuring that we can at least create some foundation, setting our communities up for success. It'll be interesting because I do believe there's just so much unknown as we've been talking about. And this is where I feel like going to the next question for digital health and infrastructure, we're not technically starting from scratch. I mean, there have been opportunities, there have been different pilots, there have been things that have happened to do this already. But I'm curious, what lessons have we learned about scaling tech across critical access hospitals, FQHCs, federally qualified health centers, and rural clinics? I mean, I think any examples would be relevant. Probably Kemper would probably have a lot of insights into this one.
I was hoping Lisa would go first, but I can do it. And then I'll throw it out that way. I think what we have lessons learned in this space is, and this really started during the High Tech Act of the 07-08 era, when there was that huge investment of funding into digital health and how to connect healthcare through technology and using it as a tool to aid positive health outcomes. Lots of lessons learned, lots of choices made, a lot of good and bad and ugly things have happened since then within healthcare. I think we've learned so much, which I think I am grateful for as we hit this time of this investment that includes some technology investment. And from there, I think the key points I pull from that experience and just living in that infrastructure every day is learning what you have. What do you already have at your fingertips, and are you optimizing it in the way it can be optimized? Not always the newest, shiny, beautiful thing is the best option for your clinic, for your FQHC, for where you're sitting as a provider, whether it's clinical or social care. Really taking stock of what you have. Are you utilizing it in a way that it will best function for you? And then from there, be really critical on what is going to be a tool for you. Tech is a tool, and viewing tech as a tool. And I think we've learned that in the last couple decades is tech is our tool. Tech is not our provider. It is not the hand that holds the patient who is walking through a health issue or, working on their lifestyle changes to support more positive outcomes. It is really just that support to push people toward better better, healthier lives and better health outcomes. But I think my biggest two are learn what you have and then go from there. And don't feel like you have to be the best and the shiniest. Be what's good for the populations you serve.
Yeah,
Always.
that really resonates with me, Kemper, and just kind of where we're sitting at BioSTL, trying to be that bridge between the new technology and innovations and the incumbency, and that goes from the large health systems all the way down to the FQHCs and the rural clinics. And knowing what you have is very critical. And a lot of times, what we're spending our time doing is helping our partners, like the critical access hospitals and FQHCs really think about, okay, what is the problem that you're trying to solve? What is currently at your disposal? And then how can outside tech and innovation and vendors help you to actually solve those things? And I think the lesson that I've learned with that is it takes and Rocco, going back to your thing about moving at the speed of trust, is our ability to educate our partners around, what a vendor relationship can and should look like. What are the expectations on both parties? Are you willing to actually, and do you have the capacity to do the needed integration and the stitching together and all of these things? And then I think the role that we are pretty adept at playing is also coaching that vendor side of it to help them be better partners as well. So I think it comes down to a very meeting of the minds here between both the innovator and the incumbent to make this thing work. And there's many ways to do it, but it all comes down to trust.
Yeah, there can be a lot of pie in the sky, like perfect solutions that could be brought down, but ensuring that you not only know what you currently have, but know what you don't need is
Hmm.
extremely critical. All right. Lisa and Heidi, anything from you all on this one, or you want to go to the next?
I think bottom line is that you have to stay very intentionally focused on quality improvement and don't let tech be this in service to the goal. Don't get distracted by the tech for like you said, Kemper, the shiny new thing. If you keep your eye on what is best for the patient always, you will always do the right thing. And that'll help guide your tech investments as well.
Great. Anything for you, Heidi? Got off mute.
Um, I was waiting for the next question. But my thoughts on this one would be just keeping in mind how different the systems are in the funding available for what the larger health systems can do versus what a small independent rural health clinic can do, right? So, ambient AI is great when you're the Mercies of the world, but what about the independent health clinic run on Tic Tacs and duct tape down in the boot heel? How are they going to integrate that? Like, that's not even in the realm of possibilities for them. They barely have a functioning phone system, much less internet access to be able to run something high speed. So I think that's just important to remember. It's something that, when we've talked to tech companies and they talk about, being able to reach these smaller groups, they don't have the infrastructure available to them to be able to compete or to keep up with the latest and greatest. So it is almost like another world down there, versus if you are in St. Louis or Kansas City or Columbia or Springfield, even compared to places like Cape Girardeau that are smaller. So it is a very different system for them down there, and they just don't have the same access or availability to those groups.
Yeah, having a realistic expectation of, once again, the current state, not just from technology, but also, yeah, all that infrastructure that's needed if you really want to go another level. And not chasing that shiny object, although it looks good, but understanding it really can't be practical, at least for now. And I think that that's where, so thinking of current state, thinking of what is, I guess, possible. If you want to stay on, Heidi, I know you're excited about this one, but the data interoperability analytics. So really thinking about, what role do HIEs, health information exchanges, community data platforms, or any form of really shared services like play in supporting rural population health? As we know, they can't do it by themselves. So there has to be this type of community focus, this relational type of way of doing healthcare. So anyone, I guess, Heidi, you want to go with this one first?
Actually, Kemper should probably start with this one. Sorry, Kemper.
Oh no, I started the last one, Heidi. You can do it, and then I can jump in. I know, unfortunately this is in my title. So I guess I should start it and then I will try not to talk too much. But I think it's fascinating if anyone has reviewed the rural health transformation application that was approved for Missouri, there is a hyper focus on that community information exchange piece within the rural counties in Missouri, which honestly is most of Missouri if you take out the two border towns and some down south. But otherwise, it has a big the brush is painted wide in the state of Missouri on what this can impact. But community information exchange is a big piece of this. And I think we have back to lessons learned and leaning back on what we've learned on the last 20 years of technology and healthcare, and even longer than that, is health and positive health outcomes live beyond just a clinical experience. It is a whole person viewpoint of a patient, and every input that comes into that patient's lives and that they interact with impacts their health and their ability to be productive citizens in the society, provide for their families, have a good long life. And that is impacted from homelessness to having access to a cardiologist when you have a heart attack. It is a huge swath of need, and we all recognize that. But the hardest part is the data that goes with it. And I think that is something we have learned, and especially in the seat I sit in at a health information exchange, data is king, but a data is nothing if you can't use it. So how do we grab this clinical and non-clinical data in a standardized way that informs decision making on the clinician and patient level across the board? And then if we're also looking at Medicaid populations or any other aging populations, these populations that are supported by different funding sources, IDD being one of them as well, is how can we also support case managers and those walking alongside these clients and patients to create better health outcomes. And that's really, a lot of that lives in the data, but it's learning how to utilize that data to inform decision making. And I think lessons learned right there, underline that 10 times, is how do we make that data worth something, and how do we move that to a place that can be used at the different levels, whether it's a caseworker on the community CIE level, or if it's a clinician at the HIE level, or it's somebody at the state who's interacting with an IDD client. Again, data is wonderful as long as you have the ability to use it, and really lean in on the insights it provides. And then put a layer on top of that is the population level data. There's a lot of things we can glean from population level data if we have good data going in. So again, I will stop talking because I can go all day, Rocco, on this one, but I will throw it to Heidi. You can take it from here.
I think Kemper is exactly right. So, and in our rural communities, the same can be said for our urban areas, right? Like the continuum of care, social determinants of health, all of the things that interconnect in communities across Missouri. But in rural areas, they're particularly important because the services are so far away from each other a lot of the times. And how are all of them working together? So transportation continues to be a massive issue in our rural communities. So what does that mean? That means they might not get to their appointments in time. They might not be able to get to the pharmacy to get their prescriptions filled every month. So things like that are captured in data. So being able to know you've got patient John who has transportation issues, and allowing the folks who are coordinating John's care to know that that is a problem up front, and they can help mitigate that by connecting them with the proper groups that might be able to help solve that. So all of that really does work together and helping each other. And that data is very important. And having everybody who might touch that patient, from the rural health clinic to the dentist office to the community action agency that, their kids in the Head Start, like all of that knowledge goes together and creates better patient outcomes.
Yeah, if I can jump in here, I going back to just what Kemper was saying about all of these different stakeholders. I think the true thing, and as BioSTL's role in the RHTP landscape, is to help the different stakeholders in Missouri, in different states, of how are you actually vetting and thinking about the different solutions that are going to help you achieve your outcomes. And I think the biggest thing we're seeing here, you see three major stakeholders here, and that's just three of them. There's many more of all of this data that is actually broken and not speaking to each other. So I think thinking about the connectivity layer between all of these different stakeholders and how they're exchanging information back and forth is the key here. But then going back to, I think what Heidi and Kemper said is, how is that data now actionable? And I think we can take a lot of lessons from early pop health and RPM tools that just created alert fatigue for physicians. How are those being, and we're seeing now as a resurgence of those types of solutions that are stratifying different things more proactively and allowing the provider and the other service providers to actually act on different things. And I think additionally is with regards to chronic care management, hospital at home programs, and the patient engagement solutions, those also have to be connected and woven into this ecosystem. So I think what we're, as BioSTL, is looking for different solutions here is, who are those players that can actually stitch this ecosystem together, and in a way that is responsive to the resource constraints that we do have in our rural entities.
I'll pick up from you again, Noah. I would say this question, what role do they play, may be better cast as what potential role could they play? Do they play a role now, actually, in a very pragmatic sense in the rural community? I think that might be one of the 3 to 5 year outcomes that we're hoping for from rural health transformation, because that would imply that we are not just collecting the data and transporting it, where it needs to go, but we're using it wisely. And I think there's a lot of potential here. But we also need to keep in mind, when we have these enormous data sets, at where the starting point is. And I would suggest, I've been very involved in patient centered outcomes research for quite a long time. And I think that is the place to start, is having patients and caregivers at the table to help determine where to start with which questions to answer with the data. And that will get us to the most quickly to the impact that we're looking for.
Well said. Yeah, and then as we think of, trash in, trash out with the data, it has to be able to speak to each other. And ultimately then that will allow us to create insights through the analytics. It'll be interesting to see where we do go, because as Kemper talked about, there's a lot of money within our HTP that's specifically focused around interoperability, things like that. So I'm hopeful that we do get the right stakeholders connected, and they actually are willing to maybe give whatever the thing is that is needed. Although it might not be perfect for them, we know that from a community perspective, this is going to be more successful. And this is where, we've been talking about it a little bit, but I wanted to take some time to really focus in on just the care models and virtual health? Because we know telehealth is going to be critical for how we actually do transform rural health. Is it going to do everything for us? No. But I'm curious if anyone have any examples of where really telehealth has delivered in your mind like the greatest impact, let's say positive impact in this way, and then where has it fallen short?
I think that we, in rural communities, we saw a tremendous impact of telehealth during COVID, right? Organizations of every size that pivoted to telehealth to continue to deliver care. And there was just a dramatic increase in the service delivery through that channel, which was necessary. The extremely steep drop following COVID and back to business as usual, I think, is where the interesting questions lie. And I think there are quite a lot of lessons to learn about cultural barriers to telehealth utilization from the patient side, the caregiver side, the provider side, and what drives the system to incentivize it or not compared to more standard methods of delivering care. So I'm very interested in the cultural barriers and really drilling down on those because I feel this has been a very well-funded area. Telehealth has been well-funded for decades. Broadband is really reaching the nooks and crannies of the rural areas. In our experience here in Southwest Missouri and with our experience with schools, for example, we have a very robust school telehealth program. Sometimes the schools have better broadband than our facilities, and it's like, let's use your backbone, right? So the infrastructure is there. So we need to look in different places for adoption and what's happening.
Yeah, those are great points, Lisa. And as someone who has looked at thousands of these types of solutions, I think where where there was a great, and the COVID was a great success story, but I think we kind of dropped the ball on you how hard it is to get someone in the front door or the side door or the back door, someone who has historically been not within an actual care pathway. And when you're actually able to grab them, whether it's through the virtual telehealth or something of that, or a checkup or something, the ability to catch them and then route them to their appropriate care model and patient journey, that's where the missing pieces, I feel like, and where it has actually fallen short is it once you reach somebody, how do you keep them engaged and get them on the correct pathway? And so what I'm seeing is just multimodality care models in virtual health, not just coming on the phone and doing this. There's SMS based, there's nudge based, there's all of these different things, taking the data, stratifying it, and finding different ways to reach folks, making it extremely easy, and doubling down on the patient experience. That's where the opportunities are. Wrapping around all of these services within the stickiness of the virtual health component, I think is where we need to go.
So story time, and I'll try to keep this short. So when back in 2019, before I came on board with my organization, the Missouri Foundation for Health paid for us to pilot a program to put in telehealth into 5 rural hospitals. So these were hospitals that didn't have any telehealth services to begin with. They paid for all of the equipment. They paid for the service fee, everything for the first year, and then kind of trickled it down. 4 of the hospitals used it, loved it, had high utilization rate. One of the main services that we used it for was to have a telehealth hospitalist. And so, you could connect. So like during night shift, if there wasn't a doc on duty, they would be able to connect with the hospitalist virtually. They could bring them into the room with the patient. It was great. We had one hospital, though, that their physician in the emergency department absolutely just refused to use it. So everything was taken care of, everything was paid for, and that doc was like, I don't trust technology. They're not going to do a better job than me. and just refuse to use it. And so when you're talking about kind of those cultural or barriers to using technology, is not just coming from the patients themselves, it can also come from the folks working in the hospital. The call is coming from inside the room. And so that became a problem, right? So there is that kind of cultural disconnect sometimes when it comes to technology and the use of it and finding the good. So being aware of that not everybody is going to be ready to just like, this is a great idea, let's all jump on board and adopt it immediately. Like, you have to be aware that sometimes folks are going to push back and might not like it, and being able to work with that person or persons on overcoming that to be able to offer that care.
Heidi, from the patient's point of view, I think that you have similar stories to tell. And if you think about someone who lives a distance from their caregiver in a rural area, and when you put a doctor's appointment or two or three, you may schedule them on a day. When you're making and setting aside that day and coming in, leaving your rural community, your farm, etc., you're coming in for a day that is a day of self-care. You are coming in to see your doctor. You're probably going to have lunch in town. You're probably going to visit some big box stores that you don't have in your rural community. You may catch up with friends or relatives that live in the city that you're going to. That whole experience, there may be unwillingness to co-opt that for a half-hour telehealth visit that we would perceive as much less disruptive, so I think there's just nuances to this, and the culture and the relationships that need to be explored, and not that they can't be addressed, but I think really digging down to the physician's recommendations as well about what are the times that we need to have that day, and what are the times that I'll see you next on telehealth. I'm going to check in on you next in telehealth, and setting expectations so that we start to blend things and help patients understand what the physician needs from them. So just again, storytelling and how to consider things from all points of view.
You're 100% correct. I have actually another story later and another question that talks exactly about that.
Speaking of another question, so we're going to move over because I know time is of the essence. But this one I feel like is very timely because as we think of funding changes and all these different pieces, we've talked a lot about patients, which is critical. Like it needs to be patient-centered, but really we can't not see the elephant in the room that is like current healthcare workforce, sustainability, burnout, things like that. So, in thing with technology, how do we think digital tools can help to stabilize the rural workforce rather than add to the clinician burnout?
The first thing that comes to my mind here is workflow, workflow, workflow. Just because and that's where we try to coach a lot of the vendors and startups that we work with, is you have to be absolutely obsessed with the end user's pain and workflow to be able to, one, get adoption, but also to show your outcomes and show that you're actually being able to decrease the burden that all of our healthcare workers deal with, from, an MA all the way up to a clinician. Getting folks to actually operate at the top of their license is the key here. And also, how are you actually helping your clinical champions and your other champions overcome that organizational resistance? So I think the way that they can do this is absolutely getting to know what it is that their end user deals with on a daily basis and become obsessed with that problem. And that's everything that we say to the folks that are, especially the ones that are looking to sell into rural entities, is that there's going to be even less tolerance for, am I double screening? Is the integration not here? Is the latency bad or stuff like that? So stakes are very high.
I think the reframing that technology is a tool and really leaning into that word as a tool and as is a system or a facility or what have you, bring on these tools to really be mindful to track the usefulness of it. Dashboard, not to add more burden for more tracking, but part of that vendor build and bringing those new vendors or utilizing vendors you already have in technology is ensuring you have a way to track usage and understand, is this actually providing support? Is this tool providing what is expected of it, or is it adding more burden? Because I know on the data side, we look at the no wrong door approach, which I think there's no wrong way to provide care. There are wrong ways to capture how that care is given or how that support is provided. But I think, leaning in on what Lisa and Heidi were talking about around cultural changes and the handholding of that power, that speed of trust piece here is knowing that we're sitting at a place that there's no wrong door in that technology is a tool and really framing it as a tool. And how do you provide it as something as an aid, not as something that the workforce has to be scared that it's taking their job, or they have to have fear that they have to upskill so much that they're beyond what they went to school for, or what they actually want to do for their profession. We will never not need healthcare providers or community health providers. But I think just that reframing of this is not a fear-based tactic. These are tools to support you in what you do every day. And then understanding and tracking that usefulness. I think we also have to be honest when things don't work. And when something shiny and beautiful sounded awesome and great and was going to solve all our problems and we're going to be able to build billions of dollars and we're going to make all our ends meet. But just be honest about those conversations. And again, going back to use what you have first, understand what you have first, understand what people know already, and then build on that and build with them. Don't build for them. It's very much how do you build with the workforce that is utilizing these systems and tools.
Kemper, I think there's two key workforce pieces that need to be a part of this conversation between the vendor and the clinician. And that is and again, we're talking about smaller, independent hospitals, rural health clinics, networks of clinics, CINs, et cetera. The IT workforce that they have and how to continually upskill their credentials in a very fast changing health industry. And also the question, are there project management officers at these facilities? Because IT's job is to implement and fix. And between that and the ongoing analysis, to your point, of what is the data, is the system working how we needed it to, and that constant bringing the teams together to analyze how to, tweak it to get to the healthcare improvements we're looking for and those very rewarding clinical outcomes that will help fight against clinician burnout. But those are two key workforce roles that may not be super well developed and supported in smaller rural facilities and networks.
All right. So I'm interested to see, so we talked a lot about various parts, but I know the term ecosystems come up a bit. It'd be interesting to learn more about what makes a technology or a vendor partnership successful in the rural environment. I think, Noah, you've been talking about that different ways. What would you say has been the most critical part of ensuring that successful partnership?
Mhm. Yeah, I think back to what I was saying about kind of being very in tune to the pain that your end user is dealing with on a daily basis is exactly where you need to be. You need to put yourself in their shoes. What are their limitations? This comes down to obviously the electronic health record question, which is innately different in the rural setting, Meditech, eClinicalWorks, all of these sort of, call them outdated if you want, but they are the things that you need to be able to work within to be able to be successful. And then I think a few other things here that we've seen vendors become preferred partners for our rural strategics is they are building the things that are what they are being very responsive to the pain points that are today and not tomorrow. Um, and so that's sort of what we've been seeing as sort of success here.
I think it's important to remember that you need to involve our rural communities in the discussion. So instead of saying this is what you need to ask them, what is it that you need? I mean, and that's a really important distinction, right? Like if somebody's coming in and saying like, you have to do this and this and this. I, no, they're like, that's not my problem. Like those are not the things that I am concerned about in our area. This is what my problem is. This is what would be helpful. And so actually listening to folks instead of prescribing what you think or what big tech thinks is what is important.
Agreed. And that goes with what Noah was describing of how do we ensure we know what people really need, like understanding the work, but then also having that openness to co-create with. Like it's definitely not a us them. It has to really be like arm in arm, hand in hand, working through these solutions together. All right. Lisa, Kemper, anything? Till we go to the next one. All righty. Okay. So this one definitely would be interesting. There's definitely two questions. I'd say as we've been talking through it, I want us to be open to like figure out which one made the most sense that we haven't talked about quite yet. I'd say we have been talking about community trust a lot throughout this conversation. So I think that we understand that it's really critical for it. So I'd be interested now then to think through another somewhat maybe smaller elephant, but a relevant one around how do we ensure that technology adoption doesn't widen disparities, whether that's for like older adults, low income populations, just I say generally those on the margins, those that may not be as focused on with the general care model that we have. So how are we going to ensure that we don't make disparities worse while also trying to make healthcare more accessible?
So I don't mind starting with this. I'm actually going to piggyback on what Lisa said earlier about, the relationships and the culture. So I had a research partner reach out to us, and she is doing a study on the usage of technology to create medical appointments as well as to talk to their physician in like MyChart, right? Those types of systems. And so she works with dual eligibles. She has all of the information for dual eligibles all across the country, and they were able to filter out a lot of things. So when looking at dual eligibles who are exactly the same in rural and urban areas, so these were folks who had a computer, had a smartphone, and had broadband access. So all three things were the same in rural and urban. And the rural folks were more than 10 points less likely to use those systems than their urban counterparts. And so she asked me, she said, why? Why would that be? Why, if everything is the same, why are the rural folks not using it like the urban people are? And I said, it's cultural. So when you are friends with Sally, who works at the front desk at the local FQHC, you call Sally up and you have a quick conversation, you make your appointment, and then you talk about your plans for Saturday. You run into your gynecologist in line at the grocery store, right? Your kids play sports together. Like it is small town USA. It's rural America. People know each other, people care about each other, and those personal connections are important. And a lot of the times folks think technology takes out the person of that. So instead of calling and asking for Sally, you're sitting on your phone making an appointment. Well, what's the fun in that? You want to catch up with Sally. So I think that's important to remember, that those connections that we sometimes lose in the more urban areas are still very much present in our rural communities.
I would underscore as well that don't assume a lack of diversity in rural communities. Okay. It may look different than in urban communities, but there is a lot of diversity based on the industries and migration patterns and resettlement agencies that are working in different places. We have one school district in an extremely rural, impoverished county that has 17 languages spoken at the school district. And of course, in rural areas, there are not specialized resources to help address all of the language barriers and interpret some of the cultural barriers that are there. I'm not saying that whole 10 points could be attributable to that, but maybe dig a little deeper and see what impact that has as well. The other thing just about this very largely that I would mention is social determinants of health, health related social needs, they are not intractable, right? People are very resourceful. You lose a job, you have greater needs, you get gainfully employed, you're back on track. As we collect the data and put it into our data sets, we can't treat it like chronic disease diagnoses that are going to be lived with for a very long time. We have to respect the more volatile nature of those and the tendency of people to move all the time. If I had a transportation problem, I moved. I no longer have a transportation problem. So I feel we need to treat this data carefully so that we don't crystallize people and end up creating disparities based on a point in time shot of data that came through our dashboards and analysis and so forth. It's very tricky and very sensitive. I don't know how to do it, but I'm aware of the danger of not doing it.
Mhm. I think just going off of what Lisa said and flipping it maybe to the providers and the healthcare entities within these communities and not painting them over with a broad brush of, well, they could never adopt this ambient listening solution. They can never adopt this type of solution over here, um, it- only because of their resource constraints or their infrastructure or what have you. What we're seeing as we're working more and more with these partners is that they're actually on the bleeding edge of a lot of these things. They're wanting to take bigger swings on this type of stuff. And additionally, they're actually more nimble to do so. As someone who has banged his head against the wall trying to work with the BJCs and Mercies, no offense, Rocco, you guys make it very difficult to kind of make decisions and do things, whereas entities like we're talking about, there's not a ton of red tape. And if you can get folks on board, show them the value of certain things, and then walk them through how it fits into their workflows, those things are amazingly quick at being adopted. So again, just along with thinking about patients in a different light, also the entities that are providing them the care, they're also very much able to take on these solutions. They just need a little bit of education and help.
Agreed. So what I'm going to do, because time flies when you're having fun, we generally have this piece. I'm just going to go straight into the questions just so we can see these real quick. See what we got. All right. So we got a few things. Okay, go to the first one. The first one really is a specific question is, so with Epic and other EHRs rolling out native Bluetooth device integration where remote patient monitoring hardware flows directly into the chart without a middleware platform, do you see rural health systems wanting a simple plug and play setup, or do they still need a full basic platform to like do all the different care management things like that? So I guess for this, thinking through like what level of integration, I guess, are we thinking about when we think of rural healthcare?
Yeah, I mean that we talk about this all the time with as I said, the myriad of different EHRs, telephony, different patient engagement type of things that are out there that vendors and others need to connect to. We're trying to find, are there other ways of integration, right? There's overlays, extensions, MCPs, all of these different types of ways that are a little adjacent to the traditional full-on EHR integration that almost allow you to do sort of a crawl, walk, run scenario. And in the crawl stage, it's very lightweight on these organizations to be able to integrate and adopt certain things, show value, and then say, okay, if we just do a little bit more, now we're able to do this, right? The read and write function in EHR, that's going to take a little bit, but we saw how much value is at this stage. Now we're more incentivized to keep going into this. And so we're getting, what I'm seeing is a lot of really interesting technology around the integration things where it's getting a lot easier. And so I'm hoping that we find some of those really good founding teams that are willing to do the hard work of integrate these types of interesting solutions for both the vendors and who they're trying to serve. Just because it's astounding what is out there now, and hopefully is going to be a lot less painful for this uh, type of things.
I've seen movement from our patients to push us to take direct feedback from them. Hospitalized with a, implant blood sugar monitor and saying, don't come at me with those needles, just take the reading and integrate. What are you doing here? Don't. So and I think as more and more of those things are enabled across the devices and for different populations that our payers are supporting the purchase of those devices and that the systems that they want to accept that data and we can get the HIPAA and consent issues out of the way. There's a willingness because that also is back to trust perceived as I'm sending it straight to my doctor, right? That's a good through line straight to the person who needs it in a patient's perspective.
The next piece we have looking around standardization and health information exchanges. I think, well, the question we'll see on here, basically thought 4.2 CFR. Honestly, don't know what that means. Does that sound relevant to you, Kemper? I guess what?
Yeah, I understand it. So it's behavioral health data and how it's protected and kind of break the glass scenarios in that space. I think so they were really restricted around that data and then they became less restrictive, but everyone is interpreting as the person who wrote that comment differently depending on who you ask and what that means. I think it is a good call out around standardization of data, and as data standards and laws and regulations evolve, they are changing. And I think that's something we've learned in the last couple decades in interoperability and data exchange is the need to push for more standardization across the board. I'm not going to give a very good answer to this right now because there isn't. There isn't a standardized way of managing this right now because everyone has interpreted based on their own experience and their own legal teams. That is not wrong. That is 100% true. I think this is where regulation states at the federal level can step in and help support that. With HIE, CIEs, anybody who's moving data, working with data, EHRs, all of them have their own standards and their own data sets and their own way of looking at things. There are some, FHIR-based standards. There are some HL7. There are some things that are commonly accepted, but we live in a very large country that does not have universal data standards right now. So that's a horrible answer, and I grapple with that every day on the mix of the standards we live in. But it is something we're looking at least at a state level in Missouri, and any input we're giving on the rural health side of really how do we build that standard data set and the standards around sharing data, and especially around sensitive data, and making sure it goes where it needs to go with a consent process and an eye to security and risk. So it's a very long answer without a real answer, but I understand your question and we are working on it.
There you go. And then the last one, a lot around, we have all these plans, but where is the money? Like how the resources are actually being allocated from the federal government? Since, time's of the essence, but financially speaking, how do we ensure that the funds get where they need to so we can get this stuff going?
So I can answer that. So the very quick answer is, so the state of Missouri applied for $200 million a year. We were awarded $216 million a year. So what that means is that we had to send our budget revisions back to CMS, and then they had to approve those. Apparently, that went back and forth several times before CMS approved that. Those budget revisions for that extra $16 million a year. That finally, I was trying to remember when that actually was allocated. It was not that long ago. I think it was mid to end of April. That money finally was released back to the state of Missouri. So things are starting to move. So you're right. We are halfway through 2016, good Lord, 2026. And
Not quite.
time capsule back. We're halfway through 2026, and we have to spend $216 million in 6 months. So what the state plan is currently is they are doing large projects this year. So there was information sent out to all of the hospitals to submit for they could get up to $1 million for hospital improvement funds, which in the grand scheme of things is not a huge amount of money. So those, all of the technology stuff they're hoping to wrap up this year, those sort of like big things that are going to really eat up a lot of those dollars. If you keep an eye on the website, and I'll put the website in the chat, it will have all of the RFPs as they come open. Currently, the one just opened up for the ambient AI RFI just opened up. They want that by June 1st. And then the social care referral platform that's opening up in Q3. And they're looking for feedback on remote patient technologies that should be coming out here anytime. But yeah, things are moving a little bit slow. I know there's a lot of heartburn for all of the organizations kind of involved in this because the state's not exactly known for being very quick to turn around contracts and stuff. But we have been assured by Director Bax that the state is ready and is willing to get all of that stuff out. So all of that $216 million has to be allocated, contract signed, checks out the door by the end of September. And then they will have all of 2027 federal fiscal year, to spend that money. So federal fiscal year starts October 1 through September 30th.
To clarify, Heidi, it checks out the door. Doesn't that mean, and I'm asking as a provider from the federal to the state, actually the recipient organizations who are contracted by the end of September have until September 2027 to expend the funds on the proposed projects, right?
Yes.
So what we're anticipating is you're going to start to see a double up of RFPs for this current fiscal year, and pretty quick, the same RFP or similar for the similar purpose for the next fiscal year. So you actually get longer to spend that money.
Correct.
Is that an accurate assumption or?
Yes, that I would say is an accurate assumption. So we'll start seeing the RFPs for fiscal year 2027 at the very end of this year. We also have some changes at leadership with the Rural Health Transformation Program. So I think that is also delaying the process a little bit. But yeah, I mean, Director Bax, I was in a meeting with her and she put it as it's kind of like the Hunger Games, right? Like if we don't spend this money, may the odds be forever in your favor. So, if we don't spend this money, Kansas could get allocated our money or Nebraska could get allocated our money. But if we are successful, and maybe Kansas and Nebraska weren't in spending their money or having good outcomes, we could then in future years get more money. So it is, the feds have set it up. It's kind of a little bit of a competition, but it is a lot of money that we have to spend within the next 6 months. So we're expecting a lot more to be released over the next couple of months. We were told when that money was released within the next 90 days, a lot of stuff would be coming in. So I put the link in the chat that has all information, rural health transformation. There have been some very good webinars that the state has put on. There are links to them in there. So if you go to that, go ahead and listen to those webinars, particularly like the overview one that will really lay it out. They had a hospital specific one that they did. They did a non-hospital clinical providers deep dive.
There's
they
one
didn't start
today,
recording
right?
that until
Today,
halfway through. Yep. Oh, it's not showing in the chat. It should be.
Yeah,
Oh,
I think
hold on.
that
Let me send
how
it
ours are set up.
to.
Yeah, we
Can
can
I
send
send
it
it
out to
to everybody?
people.
Okay, cool. Sorry,
Yeah,
I just noticed that it's just to us. So we'll get
panelists
that
and
sent out
hosts.
to everybody. And yes, so the community institutions deep dive, so that's CBOs, LPHAs, those sorts of things. That's today at 1 o'clock. You can register online, but again, all of that's on the state website. So Rocco said he'll send that link out to everybody. There's timelines, there's a whole bunch of stuff on that website. And I'm always happy to answer questions about that and let folks know kind of where it stands. Um, and we'll be doing a lot with our organization, letting people know what's going on.
Thank you, Heidi. Speaking of links, this is if you all have a QR code, like the phone or anything, this is just like do a survey for this event, see how it went, give us your feedback just so we know the good, the bad, and the different of it. Like I said, I'll be sending out to everyone who registered for this event the links that Heidi talked about, a link to this as well. And really just wanted to thank you all and want to thank all of our panelists for making the time here to talk through something that's honestly, we're kind of building the planes we fly it, right? We're trying to figure out how do we truly transform rural healthcare in a time where we are in a pressure cooker, as one of the audience members says. So thank you all for your time here, and definitely reach out to me if you all can, and I can connect you all with our panelists.
thank you.
Perfect.
Thanks, guys.
Thank you.
Everybody.